Good afternoon. Welcome to the WHO session to give an overview of WHO's work, what's coming in the next 12 months. So the objectives of this session, as I mentioned, are to give an overview of WHO's work on eye care, talk about what's to come in the next 12 to 18 months, and then we will hear from some representatives from a couple of countries, Nepal and Paraguay, and also a representative from the NGO sector as well, to talk about how these settings and countries and organisations have utilised the WHO tools. So I should introduce myself first. So I'm Stuart Keel. I am a technical officer within the Vision and Eye Care program at WHO in Geneva. I've been in the program working on this topic within the NCD department for the last 5 years. So I'm going to start now by doing a presentation to give a brief overview of WHO's work on the topic of eye care. To start with, I actually wanted to just give an overview of the function of WHO across the three levels of the organisation. So at the global level, where I am, we have WHO headquarters. We're based in Geneva. The primary role at headquarters is to provide overall leadership and coordination of specific health topic areas. Of course, ours is on vision and eye care, set norms and standards, and work on surveillance at the global level, support regional level surveillance as well. So just to give you an idea, at the moment we have 3 staff members in Geneva, but we also have 7 full-time consultants that work to support our activities on vision and eye care. So we are a reasonably good-sized team at headquarters. Then we have, at the regional level, we have 6 regional offices, of course 1 in the Americas, 1 in Southeast Asia, the Western Pacific, the African region, the European region, and also the Eastern Mediterranean region. And the role here is to really adopt the norms and standards that are set at the global level, explore opportunities with other relevant regional activities and integration of different health programmatic areas in broader activities such as primary health care, etc. And then we also have 152 WHO country officers who play an extremely important role of working closely with member states, in particular ministries of health, to provide on the ground planning, implementation and monitoring support for specific health program activities. Now back to the topic at hand, which is WHO's work on vision and eye care. And I wanted to start with a couple of quite sobering statistics. And the first one is, and they're related to the 2 leading causes of vision impairment and blindness. And many of you will know these figures, but I think it's important to set the scene. And we know that cataract is the leading cause of blindness globally, and less than 20% of people who have a vision impairment due to cataract have had access to cataract surgery and had a good quality outcome, less than 20%. And if we think about refractive error, it's only just over 1/3 of people who have a vision impairment due to refractive error have access to the appropriate pair of spectacles that they need to bring them out of vision impairment. But we know also that this is just the tip of the iceberg when it comes to the need for eye care. If we think that these are the 2 most cost-effective eye care interventions, we can only imagine what coverage is like for all of those other very important eye care interventions for glaucoma, diabetic eye disease, macular degeneration, all of those conditions that don't typically cause vision impairment but are the leading reasons for people needing care. And to confound this issue, the problem is growing. So we know that with our ageing population growth, but in particular lifestyle factors as well that are driving increases in diabetes, the need for eye care, also myopia, are also adding to this challenge. So really it's clear that new strategies are needed to address this challenge. And with this in mind, WHO member states, so countries of the world, endorsed a new resolution for eye care in 2020, and this was titled Integrated People-Centred Eye Care. And this resolution urges countries to implement integrated people-centred eye care and to scale it up as widely as possible. And it also set out a number of requests to WHO to help support the implementation of integrated people-centred eye care. So what is integrated people-centred eye care? So integrated people-centred eye care promotes that when we're planning services, it should be done so in line with 4 key strategies as shown on this screen here. And the first one is engaging and empowering people and communities, improving education, driving demand for eye care services, very important. Reorienting the model of care to build a strong primary care. We know that this is a challenge. Most services are provided in secondary level and tertiary level centres in urban centres and regional hubs. Coordinating services within and across sectors. Education sectors, we've heard throughout the meeting, the education sector, the labour sector, but also related health programs such as NCD programs, programs for maternal child health, etc. And last but certainly not least is creating an enabling environment, making sure that eye care is indicated into broader healthcare planning within countries. And we're going to hear from a couple of government representatives about that exact topic soon. So WHO's support for member states to implement integrated people-centred eye care generally fits in 3 broad areas. And the first is the development and now implementation of what we call the Eye Care in Health Systems Guide for Action, which is a series of tools to help support planning, monitoring, integration, particularly in the government sector of eye care. The second is quite a topical area, which is the SPECS 2030 initiative that was launched only 6 weeks ago, and we'll go into a few more details of that, but really an initiative where concerted effort is going to take place to address the huge uncorrected refractive error challenge. And the last is around global eye care surveillance, so we can actually map out and monitor how effective our actions from the sector and beyond have been in improving access but also quality to eye care services over the course of this decade. So let me go through each of these very briefly now. So this Eye Care in Health Systems Guide for Action, together with over 300 experts from around the world in all regions, over the course of the last few years, we have developed a range of yellow documents, as you can see on the slide here, to support a range of country-level activities to help support implementation of integrated people-centred eye care. And these range from supporting planning, doing situation analysis of the eye care situation in a country using what we call the EXAT tool. Then we have the package of eye care interventions, which is really providing a blueprint of what eye care interventions should be provided at the different levels of the health system and across the continuum of care from health promotion through to vision rehabilitation in order for us to achieve universal health coverage in eye care. We then have specific tools to support monitoring. We have a standardised eye care indicator menu. We also have a DHIS2 module to support facility level monitoring as well. Human resource development tools taking a competency-based approach to addressing some of the HR challenges that we've heard about again throughout the meeting. And also some health promotion tools. We have a new WHO app, population-facing app to raise awareness and also offer a very simple solution to screen distance and near vision, and another tool for a systematic message-based program for myopia as well. So I encourage you all to go to a WHO webpage to learn more about these tools, and if you've got any questions, please refer back. Just wanted to show that we're very happy now that WHO is supporting the implementation of one or more of these tools in over 20 countries. This includes just the support that's provided by headquarters and the regional office. So we're very happy, and also, of course, many of the partners in the eye care sector are also supporting implementation of these tools as well. Looking now at the SPECS initiative, and I feel like I've presented these slides probably 50 times in the last 6 weeks. So apologies to those that have seen it, but I think there's quite a few that may not have seen it. So really acknowledging that of course refractive error is the leading cause of vision impairment amongst child and adult populations. It's a huge, huge need for care. There's a range of stakeholders involved, and there's a number of challenges, and one of the key challenges is relatively limited governmental sector provision of refractive and optical services, which leads to quality, affordability, and accessibility related issues. So with this in mind, WHO launched the SPECS initiative, SPECS 2030 initiative 6 weeks ago, that has the vision of a world in which everyone who needs spectacles has access to quality, affordable, and people-centred refractive error services. It has the mission to support the achievement of the World Health Assembly endorsed target on effective refractive error coverage that we'll see later, but I'm sure you've heard about throughout many of the sessions today, but it's a 40 percentage point increase in effective refractive error coverage. And the primary focus, given WHO's role and links to ministries of health and government, is to support and strengthen the provision of refractive services within the government sector specifically. So I won't go through all of the ins and outs of the strategies and the country level recommendations that have been made through engagement with the sector, but what I will say is that, of course, an ambitious initiative like this will need collaboration and coordination across all relevant stakeholders, and WHO SPECS 2030 initiative has 3 separate areas of engagement. The first one is with the private sector. There will be specific private sector dialogues that happen through the course of late this year and early next year to seek meaningful contributions to scaling up access, particularly in low and middle income countries. We'll be developing some additional technical tools to help support the implementation of the recommendations within this initiative, and of course we will, like always, WHO will rely on individual experts to contribute to the development of these tools. And lastly is the establishment of an official WHO network of stakeholders called the Global SPECS Network. And this network has been pulled together to really promote united action and coordinated advocacy towards achieving these goals. And we were very, very happy to bring together the inaugural members of the SPECS network to the meeting a couple of weeks ago, 6 weeks ago now, to the launch of the SPECS initiative, where we really mapped out the work over the course of the next 2 years and helped shape the work over the next 2 years. So just to mention that if there's any other interested organisations in joining the Global SPECS network, there'll be open call for applications again in September this year. And the last area of work I wanted to mention is global eye care surveillance. As I mentioned before, we need to be able to effectively track how well we are doing as an eye care sector in increasing access and quality of eye care services. The actions of WHO, of all of the partners, we need to be able to track progress. So with that, our main focus is on tracking the 2 new global eye care targets that were endorsed in 2021, but again by member states at the World Health Assembly. I mentioned the refractive error target before, which is a 40 percentage point increase, but the cataract target is a 30 percentage point increase in effective coverage of cataract surgery by 2030. So of course there's a much more comprehensive range of indicators that are needed to track progress at a country level. However, these indicators really serve as tracer indicators to monitor progress in eye health, as I mentioned, over the course of this decade. So importantly, we've been working with academic partners since these targets were endorsed to pull together as much data as possible. The baseline report for these targets was published a couple of years ago on World Sight Day. And one thing I wanted to mention is that these indicators don't just represent good tracer indicators to monitor eye health, but are now being recognised as good tracer indicators to monitor universal health coverage in general. And that's, of course, the key goal of WHO. And evidence of that is that effective refractive error coverage has now been included within WHO's new global program of work, which really sets the program of public health work global public health work over the next 3 years, and also WHO's work over the next 3 years. So after the many efforts from the sector to raise the profile of eye care, we're now seeing some benefit from that. So very last thing from me, the key next steps for these 3 areas of work with the Guide for Action. We'll be publishing some additional technical resources, some priority technical resources to help support implementation. Zhao is very soon going to come up and talk to those. Also continue to support member states with the implementation of these tools. With SPECS, coordination amongst stakeholders is very important, and that's a key role we will be playing across those 3 engagement areas that I mentioned before. We're also really engaging further down from headquarters now through the WHO regions and country offices to identify priority countries and countries that are interested in implementing the SPECS initiative. And lastly, with the global eye care surveillance, we're in the process of working with our academic partners to produce the updated estimates, the midterm estimates for both of these global eye care indicators that will be published either late this year or early in 2025. And we're also been actively working to include these indicators within broader health surveys as well at WHO and also beyond, so that we can increase the scope of potential sources of data for these indicators. So with that, I will now conclude my presentation. I would like to now welcome Dr. João Vitado. Dr. João Vitado is an ophthalmologist from Brazil, but also a consultant with the Pan American Health Organization, and he's going to talk about some of the upcoming WHO tools that will be published in the next 12 to 18 months. Over to you, João.
Thanks a lot, Stuart. Hi everyone, buenas tardes, boa tarde, good afternoon. It's a great pleasure for me to be here. It's good to see an IAPB event here in the region, right? I've been in Buenos Aires in 2008, and I learned a lot from that, and I'm still learning, and I pretend to keep learning from the experience you guys bring to us, and I'm really glad to be here. Thanks a lot. So my job here, as Stuart said, is to present 4 new tools that WHO is currently working on, and you can expect to hear from WHO and also here in the region from PAHO. We will organize launches, workshops, and we are happy to assist you in a national level, on a regional level, and in any way we can. So the first technical product, and all of these products will be available within the next 12 months. So the first technical product is the minimum quality standards for cataract management. We are all talking about cataract, its importance, et cetera, et cetera. But WHO identified a gap in terms of number, quality, all sorts of difficulties in having evidence-based guidelines in the area. So it's this tool, this quality indicators is a list of minimum in terms of evidence-based quality standards to support countries not only in surgeries but in planning, implementing, and monitoring cataract surgeries, and it has to do with preoperative, operative, and post-operative and follow-ups. As an example, considerations regarding screening, examination, selection of lens, sterilization, incision type, surgical procedure, and use of eye shields, etc. And the aim is to have these documents for service planners and service providers for low and intermediate resource settings. At the moment, WHO is at the point that they are identifying existing guidelines and evidence for cataract surgery. And then the next step within the next few days will be working on extracting recommendations. And so far, over 160 organizations were contacted. Then the next step will be scoping reviews, draft quality standards, external review period from experts in the topic, and the publication early next year. The second technical product is a training and assistive product, and I don't know if you had a chance before to be online on this gate/tap.org. And there's a platform there, and the TAP module is an interactive training to support the primary healthcare workers, and we all been discussing about the importance of primary care in integrating all sorts of services, right? And the TAP is it's to support the primary healthcare workers and screen, identify, and refer and provide simple assistive products like hearing aids and reading glasses. But the next modules will be developed also for hearing and vision screening children, school-age children, and how to dealing with some eye emergencies, red eye, eyelid problems, and etc. And in a very user-friendly way that it will have cases, examples, quizzes, and downloadable materials and tools for that. The third technical product that will be available in the next 12 months is a WHO eye care planning and costing tool. And we will have these options for the effective cataract surgical coverage and the refractive error coverage as well. And here, in this case, we aim to estimate the resource and the cost of scaling up the coverage to reach what we need in terms of our goals to 2030. And we will, in terms of inputs, what we need for that is we need the resources defined in the package of eye care interventions, the ERAC and the ECSC country estimate. And for countries that don't have their data, we have estimates, extrapolations, and estimates from WHO/the vision loss expert group, demographics, and also incidence rates for refractive error and cataracts. The results will be the cost of human resources, medicine, health products needed to reach the targets by 2030. And it will be available late, still in 2024. And the fourth technical product is a sensory impairment intervention survey. Stuart mentioned that WHO is focused on like integrated and people care, not only vision. And this new tool is a population-based survey methodology that will be not only for eye care, but for hearing as well, free of charge. It will be available in all 6 UN languages, including Spanish. And we will have modules for preparation, training, and pilot surveys. And we will be able to adapt modules according to our needs. For example, if we are planning to work with older adults or only with kids, and we will be able to adjust the survey according to what we are, what we need and what we expect. And the results will be these indicators we need for service planning, the quality gaps, and the prevalence of vision and hearing impairment. That's it. Thanks a lot, and we'll have moments for question and answers, right?
So thank you very much, João. I'm sure there will be a number of questions, but we'll hold the questions until after the panel discussion. We'll have some time after that. So now we'd like to move on to the panel discussion component of the session, and I'd like to introduce the panelists up. So if you'd like to come up as I call you, that would be fantastic. So first we have Dr. Sofia Maldonado, who's the Director of the National Eye Care Program at the Ministry of Health in Paraguay. So welcome, Sofia, if you could come up to the stage. Yes, give her a round of applause, thank you. We have Dr. Krishna Podal, Division Chief Policy Planning and Monitoring Division at the Ministry of Health and Population in Nepal. Welcome. We have a familiar face, Ms. Sumrani Yasmin, who from Sightsavers, the Deputy Technical Director, Eye Health and Uncorrected Refractive Error, Sightsavers. And I'd also like to call back up João, who I introduced before, so I won't introduce him again. So I'm going to start with João, actually. We just heard from you, João, about the minimum quality standards for cataract management. So one of the key findings from the baseline report on effective cataract surgery coverage was that 1/3 of people who received cataract surgery did so but didn't achieve a decent quality outcome. And this was at the 618 level, not even the 612 level. So we can only imagine what the gap would have been at the 612 level. So Zhao, WHO is developing this tool with the support from the sector, of course. Can you comment really just on the importance of establishing minimum quality standards for cataract management and reflect on any experiences you have in this regard in the region?
Oh, thanks, Stuart. Yeah, very interesting topic because in our practice and in our classes, we usually say that cataract surgery is very cost effective and it's relatively simple, and it restores sight. But when we look at the data we have from population-based studies, we see that the majority of people were not seeing well after the surgery. And usually the specialist, the surgeon, think about the intraoperative issues that might happen. But when we see that there are a lot of pre-operative measurements that can be done to improve the final result and the follow-up and the monitoring after the surgery that can help, for example, refractory errors, uncorrected refractory errors are a key cause of visual impairment after surgery. So we need to do more and better. So these guidelines are developed in a way that they can assist the institutions and countries and regions to do more and better. So we need, obviously, we need to do a lot, like electronic records, involve the primary care workers. We have a very limited number of guidelines. So like we have just a very few guidelines, for example, in Portuguese and Spanish. So we need these guidelines with the current evidence indicating the gaps and what needs to be done in the national level and regional level, because we are less than 6 years away from our 2030 deadline. So yeah, so and these guidelines come to help us on it.
Thank you, Zhao. And I think it's also important to reflect on how just improving quality of the outcomes of cataract surgery can go a very long way in reaching that 2030 target without even, before we even increase access, addressing quality-related issues can go a long way to actually increasing effective cataract surgery coverage towards that 2030 target. So now I'm going to move over slightly to our country ministry colleagues from Nepal and also Paraguay. We know that integration of eye care into broader healthcare planning is very critical to ensure sustainability of eye care services moving forward. So I'm going to pose a two-part question to you both. We'll see how we manage that. But firstly, over to you, Dr. Pudal. I want to ask you, can you share any progress that has been made in Nepal towards increasing the priority of eye care within the broader healthcare policies and programs within your country?
Thank you, Stuart, and thank you very much for this opportunity. Let's go to Nepal, a small country, maybe 147,000 square kilometers, accommodating 30 million people, where the modern eye care started nearly around 40 years back, 1981, I think, if we go back, during these 40 years, enormous changes have happened in Nepal. And the prevalence of blindness from the survey, documented survey, has seen that there is a significant reduction in the number is also achieved. I mean, it's a huge achievement with the partners, with the pioneers in healthcare. I need to acknowledge them, all the partners who are working together with the government's effort. The new thing what's come up in Nepal from 2015 constitution, which mandates a basic health service free to the citizen. So this is this is the constitution of 2015, which changed Nepal from kingdom to federal democratic republic. Okay. Since then, we started working on the tools to implement that vision of constitution. So 2018, we got our national health policy, where eye care is, spoken of. It has to be integrated with the system. And 2019 National Health Policy came, Public Health Act came, where also eye care is included. and the public health regulation annexed the basic health services, Nepal's model of primary health care, where eye care is integrated into the basic healthcare system. We do have developed package for basic health service, and its eye care is included in that. And the majority of eye care services, which are more of specialist care, these are supposed to be provided by social health insurance. That's part of our endeavor to universal health coverage. So what happens is basic health service package is free of cost to the citizen, and it's provided at the local level, local government level, municipal level, where the basic health service units as well as the basic hospitals will provide this service. And after that, the further specialist service will be provided at the provincial hospitals, at the district level, and then the super specialized services at the federal hospitals. And right now we have many eye hospitals throughout the country with the support of different partners, which like we proudly say Nepal model of sort of like excellent example of PPP. And some of the initiatives which we discussed earlier are already in effect into Nepal, something like working on people-centered eye care. Like we have a school health nurse program, one school, one nurse program, where vision screening is part of it. The eyeglasses on prescription is already part of our social health insurance scheme, so there should not be an issue. Don't know, like we want to reduce our out-of-pocket expenditure in the, eye care, and the surgeries are also covered by the social health insurance. Only there are issues of equity, especially the remote mountainous districts where it's very difficult to retain human resource, very difficult to provide services, and the population is also scanty. It's very difficult to provide all the services. We're working on, like, the fulfilling these gaps with the help of local government, provincial government, and federal governments. So there are opportunities, definitely there are challenges, but we have been trying to incorporate new recommendations, and I just about to tell that we have an endorsed National Eye Health Strategy, and we recently had ECSAT survey, like we do have findings. So based on the ECSAT findings, we'll move towards the implementation of this eye health strategy, where definitely with the leadership and integration with the primary healthcare system in the country, with the help of all the partners, with the government's leadership, we want to expand sort of like these eye care services throughout the country. That's how we have been working so far.
Oh, great, thank you. I think that's a really, really amazing experience to share, and also, a very good experience and very good success story of integration at the highest level, and now starting to roll these measures out, and also the use of WHO tools, which we'll pick up on again in a moment. But now passing over to you, Sophia, I'd like to pose the same question to you. If you could share any progress that's been made in Paraguay over the last years where eye care has become an increasing priority in broader healthcare policies within the government sector. So great if you could share some experiences that you've had in Paraguay.
Buenas tardes, Stuart. Desde Paraguay, el órgano rector de lo que es salud es el Ministerio de Salud Pública. Teniendo en cuenta las iniciativas globales de la OMS, en el 2002 se crea el Comité Nacional de Visión Paraguay, que está encabezado por el Ministerio de Salud y en conjunto con otras organizaciones que se dedican a la salud ocular en Paraguay. Se empezó a trabajar en un Plan Nacional de Salud Ocular en el 2004, y es en base a esto que en el 2008 se crea el Programa Nacional de Salud Ocular, que entonces era dependiente del programas de salud del Ministerio, y posteriormente se independiza como un programa que trabaja de manera independiente dentro del Ministerio de Salud. En 1999 se realizó la primera encuesta nacional de ceguera, que sirvió también como base para el Plan Nacional de Salud Ocular, y en el 2009 se lanza el Plan Nacional de Salud Ocular del 2009 al 2020, que tiene varias estrategias que son primarias para el cuidado de la salud. Entre ellas se trabajó en 3 ejes principales que fueron la retinopatía de la prematuridad. Se creó una guía de retinopatía de la prematuridad en Paraguay. Se creó un grupo de retinopatía de prematuridad en Paraguay y esa guía fue implementada al Manual de Atención Neonatal del Ministerio de Salud, que es obligatorio en todas las unidades de cuidados neonatales a nivel país, y se trabaja en red con otras instituciones. Lo que nosotros tenemos también dentro de este programa es aliarnos con otras instituciones para dar una respuesta efectiva y adecuada en los diferentes ejes que tenemos trabajando. Es así que desde que se está trabajando con estas guías y tamizajes neonatales, se redujo del 40 al 20% la prevalencia de retinopatía de prematuridad en los hospitales de Paraguay. El otro eje que se trabajó es errores refractivos y el tercer eje es de cataratas, que teniendo en cuenta que Paraguay lleva 3 encuestas nacionales de ceguera prevenible, la segunda fue en el 2011, que se tuvieron resultados importantes de disminución de la prevalencia de cataratas, de ceguera por catarata de 3.1 a 1% entre 1999 y 2011. Actualmente nos encontramos desarrollando la tercera encuesta nacional de ceguera prevenible para ver cuál es la diferencia que tenemos desde el 2011 hasta hoy en prevención de ceguera por catarata. Actualmente también estamos trabajando en incluir a través de la atención primaria de salud todo lo que sean cuidados oculares, trabajando con lo que nosotros denominamos la estrategia Atención Primaria de Salud, que cuenta con unidades de salud familiar a lo largo del país para descentralizar un poco lo que es la atención oftalmológica a diferentes poblaciones rurales, poblaciones vulnerables a lo largo del país.
Excellent, thank you, Sophia. I think that's a very good example over time how you've really strengthened the priority of eye care within the Ministry of Health. It showed some good examples of integration of ROP, retinopathy of prematurity screening, which we know is a big challenge in the region, within maternal child health programs. Also emphasising the importance of periodic data, which we know is a challenge, but of course it's been extremely useful for you to monitor progress, but to also raise the profile. So thank you very much for sharing your experiences. I'd like to stay with you too just for a moment, because I know you commented before, Dr. Podal, on your use of some of the WHO tools. So I'd like to just see if you could share some experiences we put up a lot of tools up there. It's a bit overwhelming. Of course, the purpose of developing these tools is that they get used. So we're very happy that you've used them, and I wanted to see if you could kindly share some of your experiences.
I think the guidelines are definitely quite useful to us when we're developing the National Eye Health Strategy also. And we were the first one to use the digital version of XSAT. So we have a lot of, the colleagues from different agencies, partners, we have worked in XSAT. So it was well adopted. It was easier to adopt in Nepalese context also. So we find it very useful in our context. And depending on the country's sort of like level of development, level of healthcare, the WHO need to continue to support technically, at least the guidelines need to come through an authentic body of WHO. That's that's needed always. We look forward to having updated ones, and very much encouraged to see the minimum, the standards which you are working on cataract. We in Nepal also, we have a minimum service standard in our healthcare. We do have the minimum service standard for the general hospitals, and we are starting on the specialist hospital. Right now we have the MSS, we call minimum service standard, for the mental hospital, children hospital, and the cardiac centers. And we're about to work on the eye hospitals also, the dedicated eye hospitals and other specialist hospitals. So I think so linked, and definitely this, you gave the timeline of first quarter of 2025. We may not be able to wait till then. We want to have our MSS before that. Let's see. But it's a good to hear that you are also working on it.
Great, thank you. Yes, the very first country to use the digital version of the XSAT, which is now a much more accessible, easy to use version. And I hear from my colleague, Dr. Andreas Müller, who's been supporting implementation, that a very, very, very good report was generated from the EXAT in Nepal. So.
And Paraguay would be the second.
Yeah, so that's why pass now over to Dr. Sophia. Again, the same question to you. Any comment on the use of the WHO tools, how useful they've been, and your experience would be great.
Bueno, Paraguay, así como dijo Joao, actualmente estamos desarrollando lo que es el EXAT. Estamos trabajando en conjunto con el Comité Nacional de Visión para hacer un análisis de la situación de la salud ocular en el país, aprovechando esta herramienta que nos brinda la OMS. En conjunto hacemos esto en paralelo con el RAP, que esperamos que nos dé también datos sobre lo que es la incidencia de prevalencia de ceguera por cirugías por cataratas. Y terminando la evaluación del EXAT, estamos preparando talleres asesorados siempre por la OMS, en conjunto con todas las instituciones de CONAVIP para hacer una evaluación tanto de calidad como de cantidad de lo que es la salud ocular en nuestro país y posteriormente ver con esos resultados qué otras herramientas podemos ir desarrollando a lo largo del tiempo para, en base a esas herramientas, desarrollar un nuevo Plan Nacional de Salud Ocular.
I would like to add that because I've been following the great work you guys from Paraguay are doing. One of the key aspects of success they have is that they have a very well-organized alliance between national society, local and international NGOs, and the Ministry of Health. So by doing this, they are able to work better, work faster, and take this data as theirs and to go from there to develop the national plan. Because sometimes we go to other countries and we see that, okay, the Ministry of Health is trying to do it, but not the others. So it doesn't work as well as it's working currently in Paraguay. So congratulations. And it's good to see that in the 90s, Paraguay was a pioneer country in eye care. In the early 2000s, and they're still pioneering the eye care in the region. So congratulations and thanks.
Thank you both very much for sharing your experiences in both Nepal and Paraguay. Thank you. So now, for the final question, again over to Sumrana. So, of course, coming from a non-government organisation in the eye care sector, again, it would be great to hear from you how Sightsavers have utilised the WHO technical tools and resources in their programs within the countries that you work.
Thanks, Stuart. Hi, everyone. At Sightsavers, we strongly believe in the power of catalyzing the change at the national level. And we feel that as an international development organization, our role is as a catalyst. And WHO's tools and resources have provided us an opportunity to ensure that our programs are evidence-informed, are based on best practice, and are very much aligned with global international thinking. I'll pick the example of package of eye care interventions. So we have been using this resource to design and plan and implement our projects in quite a few countries in Africa and Asia. And that has provided us an opportunity to ensure that at the national level, the policies, plans, and government initiatives are taking those interventions on board and integrating them into their systems and implementation plans as well. There are instances where we feel that everything that is recommended as part of package of eye care intervention might not happen at the same level, at the same pace in certain context, but this then provides us an opportunity to identify the gap and then work with the partners, with ministries of health, to see how we can support addressing those gaps so we can go from point A to point B. Another example I will pick is around awareness. I think all of us will agree that lack of awareness is one of the key barriers when it comes to creating, uptake of eye care services. And Who Eyes and Myopia at toolkit has been such a great resource for us, particularly when it comes to health education, health promotion, intervention facing towards general population. And we have been adapting and integrating these tools into our programs in quite a few countries, and the learnings from those programs has also then helped us to further adapt and improve our projects as well. And one more thing that I will like to share is in context of TAP modules. Right now, we are in the process of piloting the magnifiers module as part of our vision rehabilitation program. And we are looking forward to how this is going to be integrated, embedded within the rehabilitation component of the work that we are trying to do. And the last but not the least, we also look at these resources as a great advocacy tool for us. And that help us to bring all the stakeholders together, that help us to bring, to make sure that the programs are achieving towards, or moving towards achieving universal eye health coverage when it comes to in the countries where we work.
Thank you very much, Samrana. I think that's a very good demonstration of how the tools can be used, but I think the important point is to be adapted as well. Of course, these tools need to be adapted for the local context. Most of them do, and things are going at different rates at different stages, so everything can't be implemented at the same time. So it's great to hear those experiences. So that actually finishes us up for the formal part, but we wanted to leave 10-15 minutes for questions. I thought the questions would be to WHO, but given the discussion, I'd like to keep the panelists up here as well. So the questions can be for WHO or any of the panelists as well on anything that's been discussed or any other questions that you may have. So we've got a question up the back here. I'll move over here and I'll pass over.
I'm Chundak Tenzing, Medical Director, Seva Foundation. My question is, you talked about minimum quality standards, but how about safety standards? How about not operating on the wrong eye, wrong patient, and then having a national registry of adverse events so that we can learn from our mistakes? Those are some of the questions I had in my mind. Also, a needle stick injury, because the most vulnerable, the one who cleans the biomedical, he gets poked by a dirty needle and gets life-threatening diseases. Those are also these very big concerns for us. Thank you.
Thank you very much for those questions. I can take a bit, and then Zhao, if you want to complement as well. So I think the most important thing to note is that these minimum quality standards won't just be for the procedure, the surgical procedure itself. It will be pre-operative and post-operative considerations. As you've seen, there's been a huge effort undertaken to gather as many guidelines and guidance documents from organisations around the world, from all WHO regions, to really collate all of these key considerations. And I can assure you the considerations that you mentioned before will be considered. But I'd also like to reiterate that after we do this initial development stage and we have a draft, we will be engaging quite widely with the sector to get feedback. And we know that there is a lot of work happening within IPB. There's a specific group who have also been a driver behind this work happening as well. And we will be engaging through that group and beyond to get feedback and make sure that we have included all of the key concepts that you mentioned as well, and nothing major is missed, keeping in mind that the key target audience is low and intermediate resource settings. Zhao, I don't know whether you want to add anything.
Yeah, just a few things. And I agree 100% that quality goes beyond visual acuity, and it goes beyond interoperative management. And also, it needs an approach on based on the patient's perceptions, and he or she has to feel comfortable, et cetera, et cetera. And we usually think about visual acuity, but if the waiting list is like a year or so for a cataract surgery, that's not appropriate, and that's not a high quality service we are providing. So it needs to go beyond just visual acuity or just the intraocular procedures we are doing.
Thank you, Zhao. We have a question up at the front here. Yep.
Hi there, Kevin with the Brenda Strafford Foundation. So this is around the tools that are available. So we work in the Caribbean with some small countries of 50, 60, 70,000 people, and you get the often experience of Department of One focusing on eye health in the region. So we proposed the eye care service assessment tool to help kind of get a better understanding, and there was just that fear of it's overwhelming. And so this is, I don't know if this is more of a question or a request, but I think there's a great opportunity to provide that support to smaller countries and help them break the ice on that type of work. And I'm curious what the World Health Organization is doing to try and help get more countries to take advantage of these tools.
Yeah, no, that's a very important point, and I think it reinforces the point. I haven't made this, but generally WHO will support by responding to a request from the Ministry of Health in a country. If there's a request, then WHO certainly has to respond. And some example of activities that we have done in other countries through the regions is workshops on these tools, initial introductions, but then actually providing step-by-step technical support to actually complete these tools as well. So we're very happy to support and increase the information that's available on these resources, but then also support the rollout as well. Yep, we have a question over to the left.
Wolfgang Indorfer, Light for the World. I just have a question and a comment to make about the issue of monitoring cataract surgeries. We have done some cataract monitoring outcome issues in Ethiopia, and unfortunately, as you rightly say, it's not only in the interoperative aspect. And then, unfortunately, when quite a lot of negative results have been found out in the end, with quite a number of hospitals, as you can imagine, the ranges of IOLs was the biggest issue, even so biometry was done. So I mean, we have to work in certain situations, especially if it's not within hospitals, but also when you're doing mobile surgical outreaches, that there are a lot of obstacles. And of course, it's pretty unfair just to look at the ophthalmologist, but rather to have to look at the ecosystem around him. And I think there's one issue where I feel, can we not think about developing something like national IOL banks? Ways and means that IOLs are actually available within country, not to be imported always from outside, but to have a better distribution system and having the ranges better made available. Number one, and number two, we all talk about the recommendations of the assistive devices of WHO still way back from 2015. But we still have the problem that tax exemptions for spectacles, for lenses, it's still not there. We still even struggle sometimes with viscoelastics and other issues. So I think if the voice of WHO could be announced further and louder, just to make sure that also spectacles are cheaper, available for the service providers, and in the end for the patients. And to look at the IOL bank, I think we would have achieved a lot. Thanks.
Yep, thank you very much for those important comments. So I'll try to answer, and then again, if there's any compliments from the panel, please come in at any stage. So I think one thing that is obvious when you think about it, but less obvious if you don't think about it, is that the relationship between effective cataract surgery coverage and effective refractive error coverage, because we know a huge chunk of the poor outcomes of cataract surgery are due to not having access to refractive error services. So increasing EREC will undoubtedly also have an impact on increasing effective cataract surgery coverage. So I think it's a very important, that ecosystem and strengthening refractive error services, as I said, it's not just the intraoperative complications. A big chunk of it is not having access to refractive services. So I'll jump one of your point. I think your point on the national registries is well taken. I don't have any real specific comments to add on that. But in terms of the putting spectacles on any work WHO can do around spectacles to alleviate some of these tax-related issues, trade-related issues. So WHO now has included all of the diagnostic equipment, but also spectacles on the priority medical devices list at WHO. This is only an update from last year. It doesn't only include refractive error equipment, but also includes equipment actually for all of the eye care interventions that are listed in the package of eye care interventions. But among those is refractive error. I think there's a challenge, and there's different settings require different approaches. Some are opting for more of a demedicalisation of the spectacles to in their environment, because I think there's pros and cons of including spectacles on priority medical devices lists in countries in terms of workforce implications, and we need to make sure that these things are thought about quite intensely before we trickle these down. But again, in some environments, this makes a lot of sense as well. So I'm not sure whether there's any other comments from the panel on any of those. João, Samrana? No? Okay, good. Question up the front here, and then we have another question up the front.
Lynn Anderson with the International Joint Commission of Allied Health Personnel in Ophthalmology. We work with technicians and nurses for training, and I'm addressing your comment about difficulty and complexity of documents. We were very involved with WHO on your competency framework and the materials to how to use it. And that's one of the conversations we had. How do we make this usable and friendly for the smaller societies, ophthalmology clinics, universities, et cetera, to use it? I would really encourage all of you to look at that, because there's ophthalmologists, optometrists, orthoptists, allied health, their competencies and framework for curriculum. It's very good and easy to use. Plus, I think all of our contact information is in there too. Thank you.
And actually, Sandy, I might put you on the spot there, and I wonder whether you could just share your experience in using the WHO competency framework and adapting it for your needs at the WOC.
So in optometry, it is practiced at many different levels and scopes of practice around the world. So using the eye care competency framework that WHO put out, we decided to utilize the definition that was in there to adapt it as ours with the need to publish. And if you go by poster number 32, you can see it. The goal was to be able to put together the competencies under 5 domains that are expected of an optometrist as they graduate from their professional education, with the idea the expectations are equivalent that optometry would function as an autonomous primary care provider, making it a little bit more easy to understand how optometry fits into the continuum of eye care, along from the promotion, prevention, all the way through the tertiary care. We have a place, but the place is often confused, and our goal was to take the eye care framework that WHO put out and try to develop it so people had a better understanding of what optometry is, and teach and ensure within the profession and the academic settings that the quality of the graduate will be at a particular minimum level of competency.
Thank you very much. We'll go with one last question up the front here, and then I see we're at time.
Stuart, just one quick comment. I would like to add, like from the PAHO point of view for Latin America and the Caribbean, every country that wants to use any of the WHO tools, we are happy to provide support remotely, workshops, site visits, as long as Stuart said, as long as the Ministry of Health requires that. So, because we need that requirement for the Ministry of Health, but we are happy to support in any way we can.
Over to you.
Thank you. First of all, congratulations for this amazing group. And I am Dr. Moguel, past president of the Society of Mexico Ophthalmologists. And I can tell you that we have a very huge country. We have these areas, very dry areas in the north and humidity in the south, and the populations are completely different. And obviously, following the ideas of the effect of the cataract surgery, we have to think in the effect of using glasses and indication of glasses in children, because it's not only to give the glasses. maybe they have amblyopia or strabismus, or they are losing the vision because of degeneration of the retina, etc. So we need all the ideas, and we need all the hands as working with optometrists. And obviously, we have to work together to have the preparation for, if we are looking the children, if we are following them, if we are giving the classes, we have the capacity of education to know what else is happening in one child. Because if not, we are losing the time. And the parents are thinking that the babies are well because the glasses were done, and they are using the glasses. And it's contradictory because we want to check all the children, but also be careful with that because the parents can be thinking that everything was solved. And obviously, I think the big problem in all the world is the work with the government, except in Nepal. But we can see here in Mexico how the ROP group follow very, very quickly to change the laws in the Mexican government. But when we are talking about amblyopia, nobody do that. Nobody can. Maybe it's not important for the industry, for the big pharma, etc. It's more important, and everything follows the cataract results. And nobody thinks that maybe the cataract that you operated is in a amblyopic eye, and you don't have the expectation that you were waiting. So I think that more than only give some rules, we have to work together in the ophthalmology group, and also, for example, she is the president of Low Vision. After using the glasses, we have to continue to rehab and also to follow the babies, and we have to give a very, very loud voice to tell about health, vision, and prevention. And we did in the last year a special group of community leaders for communities because everybody is different and the government in every state is completely different. And maybe we have more problems of trachoma in some states and more problems or infections, different infections in another. So it's a very, very strong work we have to do and to get together, to be together, and to follow, especially that for example, in Paraguay, that you have a very good program of to prescribe the glasses, but also to follow the children.
No, thank you. I think not questions there, but very good comments about some of the challenges in Mexico, and I think it's a good point to finish off on because it really highlights some of the key challenges that are faced in many countries in this region and beyond, but also reinforcing, the key messages about integration, about integrated people-centered eye care to ensure sustainability. Children are followed up, that we're not doing single disease-specific efforts, but rather we're taking that comprehensive approach. So I think it's a very good point to finish up. I'd like to thank everyone for joining and being engaged in this session. I'd like to also thank the panelists. So thank you very much for the panelists. If we can give them a round of applause, that would be great. But thank you very much.